Hello, everyone. As part of our Better Outcomes webinar series, I'd like to thank you for joining us online today for this very special broadcast. My name is Emily Eberly with Sachs Communications, and I am your technical producer. It is my pleasure to welcome you to today's webinar called Unplanned Extubations in the NICU, Preventing the Risk. And now I would like to introduce you to Terry Volsko, who is our moderator today. Terry is the Director of Respiratory Care, Transport, and the Communication Center for Akron Children's Hospital. She has authored more than 70 abstracts, 35 peer manuscripts, several book chapters, and 2 textbooks. She has served the respiratory care profession in many capacities, including being a trustee for the NBRC and a member of the editorial board for the RC Journal. Terry, I welcome you, and I'm so glad to be working with you for this special session, and we thank you for all of your support in moderating this important webinar for so many people around the world in our international audience today. Are you ready to get started?
I certainly am. Thank you, Emily, and it's my pleasure to be here today. I actually have the distinct pleasure of introducing our 2 distinguished speakers. Our first speaker, Kathleen Deakins, is the Clinical Manager, Women's and Children's Respiratory Care, Pediatric Pulmonary Function, and Infant Monitoring at the Rainbow Babies and Children's Hospital of University Hospitals in Cleveland, Ohio. She is a credentialed neonatal and pediatric specialist with a special interest in all facets of neonatal and pediatric respiratory care. She has published more than 50 combined abstract and manuscript publications on respiratory medicine and has lectured widely in her field. She is also a member of several professional organizations dedicated to respiratory medicine. Our second speaker is Therese Verklin. Dr. Verklin is a professor and clinical nurse specialist at the University of Texas Medical Branch Graduate School of Biological Sciences and the School of Nursing in Galveston, Texas. She is the co-editor of Core Curriculum for Neonatal Intensive Care Nursing, as well as a chapter contributor. Therese is internationally known as an expert in the care of high-risk neonates and is a frequent guest lecturer. She has been a guest editor for Joggins Clinical Issues and Critical Care Nursing Clinics. Therese is a contributing editor for the Journal of Perinatal and Neonatal Nursing. She is also past board member for the National Perinatal Association. Our speakers today have provided us with some disclosures. Ms. Deakins disclosed she is a member of the advisory board for Hillrom and Massimo. Both Dr. Verklin and our nurse planner, Lisa Cafferty, have disclosed no conflicts of interest. This activity has been approved for 1.0 contact hours of CRCE and CNE by the American Association for Respiratory Care and the California Board of Nursing, as well as the Florida Board of Nursing. At the end of this webinar, you can obtain these continuing education credits. The URL will be provided to you at the conclusion of this webinar. You will need to register on the test site, complete the evaluation form. Upon successful submission, you will be able to print your certificate of completion. Listed below are the accreditation associations for today's program. It is my pleasure now to introduce our first speaker, Kathleen Deakins, who will present on unplanned extubations in the NICU. Kathy, are you ready?
Yes, I'm ready. Our learning objectives for today are to examine the definition, causes, and reasons for unplanned extubation in the NICU, to also review complications caused by an unplanned extubation, explore interventions that reduce the incidence of unplanned extubations in neonates, and identify the processes to help improve practice and reduce these events in these fragile infants. Unplanned extubation can be defined in many ways, but a basic streamlined definition is removal of the endotracheal tube by the patient or by a staff member of the medical care, providing medical care when it is not planned. Unplanned extubation requiring intubation, unfortunately, is the 4th most common adverse event in NICUs in the United States. Unplanned extubation is potentially devastating and a very costly event because it has a variety of complications. Those include airway problems, need to undergo an additional procedure such as intubation, and also places the patient at risk for cardiovascular events. An unplanned extubation is confirmed by clinical assessment, which includes the absence of chest rise, if you're using a CO2 detector, an absence of CO2 or the right amount of CO2. And also, the endotracheal tube cannot be visualized during laryngoscopy. If you look at the definitions, the many definitions or terms that unplanned extubation is known as, they include unintended, unplanned, accidental, inadvertent, unexpected, a treatment interference, an airway accident, self-extubation, or unintentional extubation. You may hear it referred to by any of these terms. There are many risk factors for unplanned extubations, and these include agitation that can cause movement of the endotracheal tube, a mucus plug that causes the patient to be agitated, and also the patient themselves may want to pull the tube. An uncuffed ET tube is not anchored as well as a cuffed one is. It relies on the tape or the securing device. Infection, if the days on the ventilator are increased or the patient has to have repeated intubations. And injury to the airway as well. A chance of a ventilator-associated condition, and of course an unplanned extubation. There are physiological and mechanical reasons for an unplanned extubation, especially in neonates, and these include potentially longer duration of intubation because of their illness. Their trachea is shorter than a pediatric or adult patient. We use uncuffed endotracheal tubes. And the mere fact that the patient is smaller makes this very difficult. Minimum use of sedatives or muscle relaxants is a focus on this is very much practiced in the NICU to avoid impairing the development of the neonate. Studies conducted over the last 60 years in North American NICUs has shown us that the average unplanned extubation ranges from 0.14 to 5.3 events per 100 ventilator days or patient intubated days, or an average of 1.5 or 1.52 unplanned extubations per 100 ventilator days. And that was most recently calculated in 2012. The Vermont-Oxford network, who tracks data on neonates, has extrapolated a rate of less than 2 unplanned extubations as being a standard in neonates. But since 2012, there's been a lot of increased focus on this problem, and awareness and accountability is definitely growing. Factors that have been associated with unplanned extubation include agitation, which accounts for about a quarter of the unplanned extubation events. ET tube fixation, or adjusting and repositioning the tube, it is a very common procedure that is done to make sure the ET tube is maintained in the correct position. About a third of the unplanned extubations occur during that procedure. During positioning, moving the patient is necessary, but also creates the highest risk for the neonate to become extubated during that care. And also during Kangaroo Care, which is critical to the development of an infant, about 10% of the patients become extubated during the transfer or during the actual process of completing the Kangaroo Care. If you look at other less common factors, the time of day has something to do with when a patient becomes extubated. There are more unplanned extubations during the day shift. And there's a history, if there's a history of a previous unplanned extubation, that could contribute as well. An abrupt head motion most of the time occurs independently. The patient has purposeful or non-purposeful movement. And then again, as the patient enters the weaning phase and they're ready to be extubated, there's a chance that the increased activity alone could cause an unplanned extubation. So who's the most vulnerable population in the neonates where an unplanned extubation occurs? The highest risk we have found for unplanned extubation is the less than 2,500 gram range. Very, very high percentage of those patients, if there is going to be an unplanned extubation, they're under that weight. And if you look at the very, very small premature infants, less than 1,500 grams, 42% of unplanned extubations occur in that range. There has been no correlation or association with gestational age and an increase in unplanned extubations. Complications of unplanned extubations include rapid changes in vital signs, bradycardia, which can result in cardiac or respiratory arrest, bronchospasm, aspiration, inflammation of the airway structures, including the subglottic tissues, the supraglottic area, and the glottis. And then the longer-term complications include pneumonia, laryngeal airway injury, subglottic stenosis, or inflammation of the subglottic area causing the stenosis over time, a ventilator-associated condition, increased number of ventilator days required, and then an increased incidence of chronic lung disease related to increased time on the ventilator. If you specifically look at unplanned extubations in premature infants, some of the most common complications we have seen result in emergency reintubation as a result of the unplanned extubation. Repeated attempts of intubation may be required, and when that happens, there's an increased chance of infection. Repeated intubations can cause lower airway injury or laryngeal abnormalities, tracheal injury, or eventually scarring if repeatedly done. Acute hypoxia, hypercapnia, and a risk for increased interventricular hemorrhage is also can happen because in some premature infants that lack autoregulatory mechanisms that control their CO2 when they're very premature, this can be affected by these drastic changes. Pulmonary injury from manual ventilation when the patient has to be manually ventilated because the tube comes out, and of course the worst complication of all, death. As caregivers, we're responsible for being accountable for protecting the artificial airway, the natural and the artificial airway. If this doesn't happen, these are the three things that can result. A patient can end up with a tracheostomy on long-term ventilation, perhaps. In addition, can cause an increased length of stay and cost to the patient. As we all know, the goal of protecting the airway is to reduce the number of unplanned extubations. Reintubation rates average about just a little under 50%. They range from 8.3 to 100% of the time, but on average, just a little bit less than 50%. That's pretty darn high, so we really don't want the patient to have an unplanned extubation event for that reason. The chances of them getting reintubated are very high. If you look at what happens in the pediatric population when they have an unplanned extubation, it can add to the cost of care and increase length of stay in the hospital. For patients that have no unplanned extubation, the average cost would be a little over $64,000 and a PICU length of stay of 4.5 days, a total hospital stay of 10 days. If a patient became an unplanned extubation, that could increase the cost to over $100,000 and increase their hospital length of stay by 6.5 days. So it could increase almost a little over 50%. Just by having one event. So the more events you have, the more difficulties and the increased costs that can occur. So our focus on protecting neonates leads us to the fact that every touch point related to intubation and maintaining the airway really matters. Each step is critical in maintaining a safe environment for the infant, from intubation to extubation. Every touch point makes a difference. Our neonatal management focus, the key points of the airway management include every airway must be protected. The approach to each intervention may have an effect on our airway, so we have to keep that in mind every time we're doing something with the patient in our regular caregiving activities. And all caregivers are expected to be accountable for maintaining the fragile airway. So just to make sure that we're keeping a very close eye on the airway. For the past 5 years, with an increased focus on prevention, some of the prevention measures we have been using across many institutions include tube securing. We've been reviewing tube fixation procedures, tube securing procedures, looking at weaning and extubation protocols. If your institution didn't already have one, you're probably in the process of looking at that right now. Appropriate nurse-to-patient ratio. Also looking at respiratory therapy ratios as well at this point. Attention is being given to those who have a history of a previous unplanned extubation because the risk gets much greater as the events increase. And education programs, staff education on prevention measures is critical, and it has to be repeated pretty much annually to make sure that everyone remembers what the goals are, the long-term goals are. And then, of course, minimizing agitation through assessment protocols and the use of positioning aids, which we will discuss later in this discussion. We look at airway securement from the start. It's key to keeping the endotracheal tube in place. There are challenges with each type of method, and what we have found out throughout what studies have actually been done, that there is no single method that has delivered and been deemed as the most superior. So there's none that is superior over another. A key point for airway securement is to select a process that works for you and your institution, and one that your staff can be compliant with. So these are some types of devices and tapes that can be used, and these are only a few of the many. But this is a type that uses a holder and tape. This is tape. This is a holder with Velcro, and then a specialized type of tape that wicks moisture away. And these are a few of many. Our key points to securing the airway include, it's always a two-person procedure. A combination of a nurse, a respiratory therapist, two respiratory therapists, or even a physician and one of those other two caregivers can be present and must be present during any intervention when an airway is in place. The nurse and or the physician, depending on the situation, must be notified when the airway is being adjusted, so it should never be done independently of those two caregivers knowing. All members of the team should be aware of what their role is in airway stabilization, and documentation is critical, especially the tube size, the fixation type of device or tape, where the tube is located, the position of the ET tube on the chest X-ray. Documentation also helps during handoff so that the next caregiver coming on can identify where the tube was last secured and be able to follow through and make sure that it has not moved. If you look at our second intervention, establishing weaning and extubation protocols, weaning protocols help liberate the patient from the mechanical ventilator as soon as they are ready, deemed ready. They decrease the likelihood of developing a ventilator-associated condition. They allow the infant to move freely without airway complications. Also promotes oral health, and this is a real important part as well. You know, taking the tube out is best always because it decreases the chance of palate injury, especially in a neonate, and prevents the oral diversion that occurs from having something in your mouth all the time. And then also, weaning and extubation protocols decrease the potential for developing chronic lung disease. Our third intervention during procedures, suctioning. As we know, closed suctioning is very commonly used, and especially in a NICU, for many reasons, to not interrupt pressure during mechanical ventilation. It's also a clean system, fairly clean system. It's easy to accomplish by yourself in a larger patient, but in a neonate, you really need to use two persons when you're performing the procedure. The reason it's recommended is that the ET tube is thin and flimsy and can easily come out of position with movement. So that's why we always need one person to hold the tube while the other is advancing and pulling the catheter back. Kangaroo Care, or skin-to-skin contact, is an important part of an infant's development, and special precautions are needed to support infants when they're on a ventilator. The transfer of the patient, the transfer of the tubing, all these things are very important to part of this procedure to prevent the tube from being tugged on and potentially pulled out. Two studies reported that unplanned extubations during Kangaroo Care were responsible for 8 to 21% of all unplanned extubations, and we saw back on the other slide that approximately 10% of the unplanned extubations on average were due to Kangaroo Care. And then some things that are being looked at now is different ways to secure the tubing, and also some education venues for families that are participating in Kangaroo Care so they know the risks and when to notify the nurse if there's a problem while they're holding their infant. Chest X-rays is a very important part of our day-to-day care. And prior to the chest X-ray, in order to prevent issues of having to retape a tube unnecessarily, or reposition the tube or retape the tube, the head position should be noted. The body position, like is the trunk central? Is the head flexed or extended? Is the ventilator tubing secured so it doesn't pull on the tube right at the last minute, right before you take the film? And also, the position should be documented by the caregiver so you know what the position of the ET tube and the position of the patient was at the same time. The other thing is, when a patient is getting a chest X-ray, they should not be moved unless there's at least two caregivers. Now, typically there is a radiology technician at the bedside and another caregiver, perhaps even a third caregiver in some instances is required. Caregiver should document the head, body position, where the ET tube is positioned at the time of the film, so they have a frame of reference when the X-ray is interpreted. And it also assures more accurate ET tube placement, prevents unwanted extubations during repositioning. As we all know, head position does affect the position of the ET tube in the airway. When the head is extended or pulled back like this, the ET tube actually pulls up a little bit. If you look at this over here, we can also see where the head is extended, it will pull up the ET tube. When the head is flexed, the ET tube may go down, actually, go down below where you actually want it to go. So the neutral position is best. This is the position you actually want the patient in. So paying attention to these during the films is critically important to the position of the ET tube. Another thing that's real important is the head positioning from midline to or side to side. There are some instances where the head is turned to the side, such as when a patient is on a high-frequency ventilator. It's really important that the head position is noted during the time of the film. When a head is midline, your ET tube gives you a great reference point, but when your head is turned to the side, it can pull the ET tube up. And you see this often when there's a patient is on the oscillator. And you may end up, if you pull the head back up to the midline and you reposition the tube, you may end up pulling the tube out of the correct position. So it's really important to note which position it's in and where it's taped at that time. Another intervention is to address the agitation. Managing the agitation is also very, very important. Want to look at the infant's behavioral cues, like what are they doing, why are they moving, is there a necessary reason why they have to move around so much, and do they put themselves at risk for extubating. Discuss the need for sedation daily during rounds, which is real important. I think most people are doing this right now, so it's a very important part of daily care. Airway hygiene may not be effective if you have to limit the amount of mouth care and that you can do because the patient is agitated when you're doing it, so you actually have to hold back on doing your regular daily care. Your comfort measures are not effective. Perhaps you don't have the correct positioning aids or swaddling, etc. Those things may need to be used, but if you don't use them, the patient may become more agitated. And then also, in some instances, the neonatal pain scale is probably the best assessment you can use to address underlying whether the patient is having pain and what is the cause of their irritability. Our other intervention for prevention includes the need for education, reviewing concepts in the form of education. And these concepts include airway management, what our positioning standards are, and that's basically what I was reiterating before about using two persons and how to do it. What are the rules of suction safety, chest radiograph safety during and after a chest film, identifying high-risk airway, and educating the families on what is happening when you're doing all these things to the ET tube to try to maintain it and protect their infant. The future state of unplanned extubations is that it perhaps may become the next health-acquired condition, and we're looking at that since 2016. There's national attention being given to the prevention of unplanned extubations in pediatric and neonatal patients. And the Solutions for Patient Safety Network is involved in standardizing approaches for intubated patients and preventing unplanned extubations. These are great venues that help us understand what works in some institutions, and we may be able to emulate what others' practices are and improve our own outcomes at our own facilities. So our goals for reducing unplanned extubation in neonatal and pediatric patients include creating standards for endotracheal tube fixation at your institution, determining high-risk care behaviors, collaborating with other institutions on processes, positioning procedures, managing sedation if needed, and general just care management, data sharing and lessons learned, sharing your audits and reporting how you're doing things, what works best for you might help someone else, and then of course to change our practice to get the best outcomes. I'd like at this time and have the pleasure of introducing our next speaker who will complete this presentation. Therese Verklin will be presenting why is positioning important to prevention of unplanned extubations. Therese, are you ready?
Thank you very much, Kathleen. I sure am. So why is positioning so important to preventing unplanned extubations? It's important because proper positioning decreases stress and enhances comfort. Stressed babies will grab at the endotracheal tube because grasping something is reassuring. Hand-to-mouth behaviors are self-consoling. It also helps develop anti-gravity movement. You've all seen the baby sliding down in the bed, and that also places a lot of traction on the endotracheal tube. It inhibits or shortens dystonic phase while the baby remains in a fetal position, so that decreases agitation, and facilitates hand to midline and midline orientation. Positioning also stimulates visual exploration of the environment, facilitates development of head control, actually helps to make feeding easier and decreases overall work of breathing. It helps to balance flexors and extensors to facilitate symmetric postures, which also decreases tension and torque on the endotracheal tube. It has an organizing effect that facilitates development of flexor tone and promotes development of motor skills, reflexes, and postural tone. Preterm infants display motor development that is a lot different than a full-term baby. Preterms have less developed physiologic flexion in their limbs, trunk, and pelvis. Long periods of immobilization without any type of positioning device when they're lying on a firm mattress with the influence of gravity results in a number of abnormal characteristics, like increased neck extension with a right-sided head preference, shoulder retraction and abduction, which reduces forward rotation and the ability to reach midline, increased trunk extension with arching of the neck and back, a frog-like position where the hips are abducted and externally rotated, and that'll give them walking issues later on, along with the ankle and feet eversion. All of these characteristics interfere with the development of eye-hand coordination, head control in the prone, sitting, later walking phases, and cognitive development and equilibrium. And you can see in the picture that the baby is not well positioned, the head is turned too far to the left, and that there's a lot of traction on the endotracheal tube. To prevent overstretching of the joints, facilitate development of flexor tone, and prevent deformities and unplanned extubations, the neonate should be provided with a variety of positions. Goals of positioning include optimizing alignment, semi-flex midline extremity posture, with a neutral neck and trunk and foot positions. Support posture and movement within containment boundaries. You want to avoid producing a barrier of immobilization. Modified positioning and handling to support behavioral state regulation of sleep-wake states, and provide positions that encourage controlled individual exposure to stimuli while monitoring for signs of behavioral stress from overstimulation. And then you would adjust the stimulation accordingly. The sideline position can be used to improve visual awareness of hands, encourage hands to midline movement, and discourage that frog leg position. Babies can bring hands to mouth for sucking and self-comforting, which will decrease agitation. Position is best maintained with swaddling or commercial devices, positioning devices rather than single blanket rolls. And you want to position the extremities so that the bottom arm is in a comfortable position and the upper shoulder and hip are slightly forward of the weight-bearing lower hip or shoulder. Provide a small positioning device and bundle for security, but not so that the upper extremity compromises chest expansion. Alternating sides reduces head molding and may prevent atelectasis of the dependent lung. The head and trunk should be maintained in a neutral alignment, and head and trunk are in the same vertical plane. And it also will help keep the endotracheal tube in the right place, as Kathleen discussed earlier. The left lateral position has been shown to improve oxygenation, lung mechanics, and breathing patterns in preterm infants, very similar to the benefits of a prone positioning. Supine positioning can be used to accommodate ventilators, umbilical catheters, and other devices needed for acutely ill neonates. Position the baby supine with the head turned to either the left or the right is going to cause mechanical obstruction of cerebral venous return and alter cerebral blood flow, which may contribute to interventricular hemorrhage. Supine positioning does not support flexion and can be stressful to acutely ill infants. When placed supine, babies show more startle behaviors, more agitation, motor disorganization. They use more energy, and they show sleep disturbances from environmental stimuli. Use of a gel or a water pillow under the baby's head and neck will provide comfort and maintains neutral alignment. You want to be sure that the positioning device extends down to about the nipple level to prevent neck flexion, or you could use it as a mattress under the head or body of a very low birth weight infant. Supine positioning should support as much flexion as possible. Body containment increases the baby's feelings of security, promotes quieting and self-control, enhances physiologic stability, promotes energy conservation, reduces physiologic and behavioral stress, and enables stress to be better tolerated. Without positional supports, many babies travel. No matter how many times you reposition them, they move towards the sides or the bottom of the incubator, which places traction on the tube and can result in unplanned extubation. Providing boundaries using these positioning devices will stop that migration and will also conserve calories for growth and development. Acutely ill preterm infants positioned supine are often agitated. You've seen them thrashing their arms and their legs. They can be tachycardic, and again, they're wasting those precious calories. Instead of needing medications, they can often be calmed by providing a nest. You can either use blankets or a commercial positioning device, and the nest will simulate the boundaries and security of the uterus. Prone positioning encourages the baby to develop neck extension and promotes flexion of the extremities. Positioning devices can include a small hip roll or a sling to assist in maintaining flexion, use of gel pillows for head support, and secure lower boundaries for foot bracing. Use of a positioning device like a gel pillow placed under the infant, again from the top of the head to the umbilicus, will provide elevation of the body to promote extremity flexion without placing excessive pressure on the knees and elbows. This will also enable the shoulders to round forward over the top of the roll and enable the legs to flex over the bottom edge of the roll. Body containment maneuvers can help the baby with self-regulation. He can hold on to a finger or a hand, or you could cross the baby's arms in midline and hold them there securely. Safe swaddling could be done. That's positioning the baby's extremities in slight flexion and abduction. Because being wrapped in a blanket or commercial positioning device with extremities flexed simulates in utero positioning, swaddling improves flex posture and flexor muscle control. It facilitates behavioral responses and improves the development of primitive reflexes. Moving the baby is always a risk for an unplanned extubation. Picking up a baby from a supine position often produces startles, maybe apnea of the baby's preterm, and we generally see a head hyperextension. A better technique is to roll the infant prone. That flexes the head and then flex the limbs onto the trunk and pick up the baby. You could also swaddle before picking up the neonate. Kathleen also mentioned the high risk for unplanned extubation during Kangaroo Care. One technique to minimize this is to have the mother stand at the bedside and have the baby placed on her chest while she's standing there. That will allow the nurse and the respiratory therapist to stabilize the endotracheal tube and any respiratory equipment, intravenous equipment, etc. And when that's done, the mother can pivot and sit down in the chair. Much more stable and less risk for unplanned extubation. We are dedicated to preventing unplanned extubation to optimize safety when our babies are on the ventilator. We've said that positioning has many benefits and can be a key factor in the prevention of unplanned extubations. Good techniques are required to maintain optimal positions, keep the endotracheal tube stabilized, and keep that baby comfortable. The best approach is a team approach by all bedside caregivers. The team of nurses and respiratory therapists is ideal. Together, we all can make the difference.
Thank you so much, Kathleen and Dr. Verklin, for that exceptional presentation. This activity has been approved for 1.0 contact hours for CRCE and CNE by the American Association for Respiratory Care and the California Board of Nursing, as well as the Florida Board of Nursing. At the end of this webinar, you will obtain those continuing education credits by logging on to the website that's provided for you on this slide. As a reminder, you will need to register on the test site and also complete the evaluation form. Upon successful submission, you will be able to print the certificate of completion. And then listed below are our accreditation associations. And now we will get to the questions that you have provided for us for our speakers. Sandy has, there are several questions about the endotracheal tube securing devices. Sandy has a particular question about staffing though, and if our speakers have any insight about staffing issues and how those might be related to unplanned extubations. For example, staffing ratios with therapist to ventilator or nurse to patient ratios.
Hi, this is Kathy. I can answer part of that question, I believe. The only studies that have demonstrated work in this that would contribute to this question is related to the nursing ratios. There have been studies that have provided information that have shown us that an increased staffing ratio and a decreased staffing ratio make a difference with unplanned extubation. So I don't think we really have an answer to that. I think all of us believe that we do need additional people there. From a respiratory therapist perspective, we are looking at a 6-to-1 ratio on average, 6 ventilators to 1 respiratory therapist. That has not been studied per se, but I believe we are looking at that in our auditing process now for patients that do have an unplanned extubation. I think we will maybe have more information on that as time goes on, but right now I believe that's all we have. Thank you.
For the nursing perspective, I think increased staffing ratios where you have one nurse with 2 ventilated patients has shown, and this is in the adult literature, not neonatal, has shown that the patient is extubated faster out of the ICU and out of the hospital faster. And I would think that would also translate to the neonatal intensive care unit, where when the nurse would be able to see the changes in the baby's lung mechanics, get him weaned faster, get him extubated to something else faster. And the faster the baby can be extubated, then the less the risk for an unplanned extubation.
Thank you. Valerie is inquiring about some endotracheal fixation devices. At the institution where she works, they're having a very difficult time obtaining a latex-free tape. The product that they were previously using has been disconnected, and they're noticing an uptick in the trend of unplanned extubations, which she reports is attributed to poor tape adhesion. Do either of you have any suggestions for securing endotracheal tubes? And then she wants to know about also, additionally, if there are any benefits to using any of the fixation devices over tape.
This is Kathy. I can contribute a little bit to that. I believe the tape crisis, the removal of our one tape that everyone across the United States was using has been removed from the market, so it's created a gap. And the current tapes that we have and the substitutes that we've been given to try, we've tried probably 5 different tapes at our institution, I know, have not really provided a solution to that. And even if you're using a fixation device, you still have to use tape to attach the tube to the device in some cases, unless you're using one particular one. So we still need the tape to not only attach and adhere, but the adhesive has to be able to attach to skin and a device. This is a huge gap area. Right now, the only thing I can suggest is that you actually try the different types of tapes that are out there right now, the new ones that are available, to see if any of those work. The other thing is trialing the devices. Just a word of caution there. In some institutions, they've had great success with devices, but there is a very high learning curve when you're learning a new device and the exact fit and maintenance and those kinds of things. It takes time. Approximately when you're starting a new device, it can take up to 8 to 10 months for a staff to become very familiar with it. You just have to be patient during that time and be extra vigilant during the time that you're trying a device that you're not that familiar with. Right now, there is no one solution that works, but again, it has to be a complete buy-in from your unit, including from the attending physician level down, that everyone is in agreement that this is the type of device that should be used for our patients. And right now there's a gap there. So we're we're doing the best we can, but I would suggest just, testing the waters buys into it. It's very important that everyone agrees. Thank you.
For infants that are very low birth weight, Susan has a question about the securing device, especially those children or neonates that have poor skin integrity. So do either of you have any suggestions on a particular product that you would suggest that you can use to allow the tape or device to adhere to the skin better, but without causing any damage to the skin integrity?
This is Kathy again. The current products that are being used in devices, the hydrocolloid base to those products, stick very well on the very low birth weight infants. I think the highest risk is in the first, few days of life if a patient is in a high risk a high humidity incubator. It can loosen the adhesive and cause you to have to change the device more frequently, but pretty much after that, the device usually sticks very well if it's attached properly and maintained properly. As for putting something under the device, the manufacturer of those products does not recommend that you add any additional adhesives under there. Although some people do that, it's not recommended at this time. Thanks.
There are additional questions about the NeoBar. Ricardo is inquiring about the use of sedation when NeoBars are used, and if the patients are able to be placed in the prone position when you're using that specific device.
This is Kathy. Yes, patients can be placed in the prone position. The only attention you have to give to the side that is down onto the mattress is that the NeoBar itself doesn't bend, or I'm sorry, the tab doesn't bend and start peeling off. We've not seen that. And actually Therese covered a lot of this, the proper position of the head during that, using that device will make sure that it doesn't peel off. It can be used, it's used all the time in that position successfully. And I also, going from side to side is really important so you don't concentrate or actually peel off one side of the NeoBar versus the other.
As far as using...
And as for sedation during that, there's, I haven't seen that any other... Go ahead.
No, go ahead, Kathy. I was just going to add that.
Okay, as far as requiring sedation with the NeoBar, we've not seen any increase in use of sedation for patients that are using the NeoBar. Go ahead.
This is Therese. I think the biggest thing, as Kathy just mentioned, is the proper positioning of the baby. If you have an infant that is supported and is comfortable, they shouldn't be agitated where they need medications or need anything super special to keep them calmed down. I think you let the baby be the guide on that, and if the baby is moving around or thrashing around, change the position, look to see what the supporting positioning devices are doing, maybe rearrange that and see if he gets more comfortable.
Thank you. Anne had a question about moisture management. In Kathy's presentation, you mentioned a tape that wicks away the moisture. Is there anything particular that either of you do in your practice regarding moisture management?
This is Kathy. In our NICU, we try not to add we use devices in our NICU. We try not to add additional products over them in the event that there is an increased moisture, increased secretions, or increased humidity. But in some instances, you do have to put almost like a cover over it. It's a very rare instance, so it's not really recommended. But the big thing and the most important thing is in that first 72 hours during the very high humidity, making sure that the tab on those endotracheal tube holders remains on the face.
There's some particular interest in weaning protocols, and there were several of our attendees that were interested in the weaning protocols that you use at your respective institutions. Would either of you like to elaborate on that?
Sure. We will wean our babies generally according to pulse oximetry, as long as they're stable. And the nurse has the discretion to decrease the FiO2 as long as a baby can remain within desired parameters. And it's very common for us to have our babies on room air, and then fairly quickly, and then and they're maintained more with high-flow cannulas in cases than just leave them on the ventilators. We tend to get them off the ventilator pretty quickly.
This is Kathy. We also use a pulse oximetry management guideline that guides the FiO2 weaning on the ventilator, which is done primarily by a nurse or respiratory therapist, whoever is at the bedside longer. And then our parameters are weaned by a specific care path that is specific to the less than 1,500 gram babies. So it's for patients with respiratory distress syndrome. And it is a care path that uses parameters on the ventilator and blood gas or CO2s as well, whether it's invasive or non-invasive measured.
Thank you. Ricardo has a question about handling securing the endotracheal tube in the delivery room. How do you handle the vernix on the skin when using either tape or securing devices?
In the delivery room, we do go to deliveries at our institution is connected to a women's hospital. You probably saw that because I'm a women's and children's department. But they, in the delivery room, they take a, usually a 4x4 or something, and wipe the face off, clean the face off before taping. Sometimes we will put a device directly on. Sometimes we will tape and then attach the device after the patient is back in the ICU, but primarily we try to attach the endotracheal tube device in the delivery room. It is a challenge, and if the face is not cleaned prior to that, the device will come loose within the first few hours. So it is very important that it is cleaned prior to. But usually it's just a water-based pad that is used to wipe the face.
That's also what we do, although we use normal saline instead, and just remove the vernix that's around the area where we want to place the tape. Tape the airway, have it secured, and then when he gets to the NICU, then they'll look at either retaping or putting on a device.
Robert has both a comment and a question. In preventing unplanned extubations, he finds attention to detail is the #1 way to prevent them. He shared with us that if a caregiver is checking the tube and the patient, it's important to triple check everything, from the patient positioning to the markings of the endotracheal tube at the gum line. His question is that in the prone position, are there any recommendations to keep a full-term infant from turning his or her head?
Oh, that's a good one. If some of all those kids are so strong, I mean, it's almost like they're little weightlifters. Again, I think it becomes back to positioning and having the baby really comfortable. You can use a positioning. Baby can kind of be snuggled right into it, providing him good boundaries all the way around his body so that he doesn't really feel like he move. It may come down to a baby that is really sick and he's air hungry and he'll need to be sedated instead. Thanks.
Thank you. James was curious about the percentage of extubations that are caused by patient arm and or hand movements.
I was going to let Kathleen take that one because she might know statistics on that one.
I don't know statistics on that, but I do know that that is the most common thing that you see is an arm comes up, and a lot of times someone will catch the arm before it gets close to the ET tube. I think that is natural, like you mentioned in the positioning part, that babies naturally want to suck on their fingers, and that's so their hands automatically go towards their face. And so they're doing what they would think is normal, but the tube is there, and so they try to pull it. I do not have statistics on, the number of that are pulled out that way, but I think as the baby gets older, the likelihood is higher that happens, and it makes it rather difficult to, without, when maintaining a developmental perspective in your care, it does make it difficult. So sometimes, when a baby is larger, they may have to put mitts on the baby or something, but that's why, continuous, like the person mentioned, attention to detail and being very vigilant on what, details are making sure that the tube is not being moved by the patient is probably the most important one, because the patient should never be able to pull their tube out, but they do, and it's rather frustrating when that does happen.
And I think that's where nurse ratios become very important too. If you have a nurse who's responsible for 3 ventilators, and I've seen that in some institutions, I mean, she just can't be everywhere at the same time. And if you have a ratio of 1 nurse to 2 ventilated patients, she can better care for those babies because she's a little freer. She starts seeing that arm go up or that hand go up. And I mean, especially our term kids, they've got that strong grasp reflex, and they just pull that tube right off, especially if the tape is a little loose. Then she can get there, or he can get there and prevent that. And then, like you say, attention to detail, somebody should have noticed that those tapes were loose and had gone and retaped that to make sure that things were secure, and if there was a bit of a tug on the tube, that it wouldn't come out.
Well, we have reached the end of our time together, and I'd like to thank you so much for your time, both Kathleen and Therese, as well as to you, Terry, for being our moderator today. It's been such a pleasure working with you. And finally, I'd like to thank each and every one of you, our guests in the live audience today, and as well those of you who in a future time will be attending this recorded session. We thank you for your time and your very thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time.